Thank you very much, Charles, and good afternoon, everybody. Well, that's the first time I've been introduced saying this is going to be contentious, but I suppose I should know that. I thought what I'd do before we get to the Q&A is just talk in particular about monitors' role, which I know is much discussed, not always accurately, as a sort of background to the Q&A session. So I want to talk a bit, I'll talk in general terms about our overall role and then focus a bit more on our role with regard to both procurement and competition. I suppose it's worth starting by saying that the fundamental here is, as we all know, the NHS faces some major challenges, and fundamentally our role is, with many others, to help you, in fact, the commissioners and providers of NHS services, to do the best job you can. One thing I'm acutely aware of is that we don't provide any services. So that's the starting point. The other starting point is our core duty, which is to promote and protect the interests of patients. So everything we do, we bring back to a fundamental question: what's going to be in the best interests of patients? So, more specifically, what's that all mean? We have to put in place and oversee a framework, if you like, that will govern the way providers work and how they interact with commissioners. And specifically, we do four things. First of all, we have a job to make sure that the public providers of NHS services, which of course is most of the providers, are well-led, are providing high-quality care on a sustainable basis. We do that in two ways. First of all, we set standards for public providers, and we assess whether public providers are meeting those standards or not. And if they are, they get given Foundation Trust status, and that means that they have more independence, more autonomy to do what they think is right in the light of what their local commissioners, their local communities need. The second thing we do in terms of making sure public providers are well-led is to monitor how they're doing at arm's length, because they are independent bodies. But if they get into difficulty and it looks as though they're not able to sort the difficulties out for themselves, then it's our job to step in and help them sort things out. We try to do that as little as possible, but equally we're very aware that we have a duty to try to prevent problems becoming too serious. However, if they do become too serious, in comes our second duty, which is to operate what's called a continuity of services regime. This is all about making sure that even if a provider, a Foundation Trust, gets into very serious difficulty, the essential services that they're providing to their local community are still provided to that community. Now, one thing I would say on both of these roles with regard to providers, particularly Foundation Trusts, is that we need to work better with commissioners. So I know that as commissioners, you have a particular interest in what's going on in your local health economies, what is going on in your local providers. I want us to work with you. It'll take us a while to build up the capabilities of doing this, but we want to work with you in understanding what is going on in your health economies so that we can anticipate where there might be difficulties and try to make sure that they're nipped in the bud if necessary. And secondly, where things do go wrong, we also want to be in conversation with you about what we're doing to try and fix the problems, because obviously as commissioners you have a huge interest in making sure those problems get fixed. So those are the first things we do, focused on providers. We will also be responsible from next year onwards, alongside the commissioning board, for setting the reimbursement system, particularly the prices at which providers are paid for their NHS services for the tariff. So that's all about trying to make sure the provision of high quality services in an efficient way is appropriately rewarded, incentivizes improvements as well, incentivizes the meeting patient needs. There's a lot that we know needs to be done to improve the way the reimbursement system is working. It'll take us a while to get there. We're just right this week publishing, today in fact I think it is, publishing a consultation document on how we plan alongside the commissioning board to approach that task. but this will be a multi-year job to work out what to do, how to do it, and then implement it. And then the fourth thing we have to do in our new role is make sure that procurement, patient choice, and competition all work in patients' best interests. And of course, this is the bit that has been controversial and where I thought I'd focus most of my, the rest of my speech. I suppose the starting point is the legislation that drives all of this. Part of it is in the Health and Social Care Act of last year and is reflected in provider license conditions. So that's a license that we issue to all providers, and it's a condition that requires providers not to indulge in anti-competitive behavior and so forth. The second thing, the second source of all of this are the, I suppose I should say, infamous Section 75 regulations, which have just been debated again in Parliament, more properly called the Procurement, Patient Choice and Competition regulations. I think it's important to say that both of these only reflect laws both in the UK, but they in turn reflect laws Europe-wide, which already apply to health. What the government has tried to do is to tailor those laws to the health sector and then to provide a body focused on the health sector to apply those laws, and that's our job at Monitor. But if we weren't here, if those laws weren't there, the underlying laws, things like the Competition Act, the Enterprise Act, something called the Public Contract Regulations, all of those things would still be there and would still apply to the health sector. But instead of us being the ones whose job it is to make sure the rules are followed, it would be the OFT, the Competition Commission, and indeed the courts. Now, the OFT and the Competition Commission do still have a role in the new world, but it's a much smaller role than it is in almost all other sectors. And this is what the government, at its heart, was trying to do with this, was to create a sector-specific regime. It's also worth saying that this is something that the previous government, the Labour government, also did. They did it in using something called the Principles and Rules of Cooperation and Competition, and they created something called the Cooperation and Competition Panel to make sure the rules were being followed. All the new stuff essentially reflects almost exactly the same as what was there before. And indeed, the Cooperation and Competition Panel, which was responsible for working out whether the rules were being followed or not, is now brought inside Monitor. It's essentially all the same people doing essentially the same job. So things have not changed as much as I think some people imagine. These rules are fundamentally, and I'll focus in particular on the Section 75, I'll call them that because it's quicker than PPCCR. The Section 75 rules really are about trying to make sure that procurement is done well, that it's done in a way that secures the best provision, the highest quality provision, the best value for money for patients, that patients' right to choose is protected where they have that right, and that providers are treated fairly. In simple terms, that's all the rules are about. Now, I know, nevertheless, there's a lot of anxiety, particularly amongst commissioners, recognizing, of course, that you're all new to this role. There's a lot of anxiety about what does that really mean and how are we going to enforce them. Well, I'll say a bit about that, but I think probably the most important thing for me to say is that our philosophy here is that it's our job to help you and others do the right thing, to follow the rules. It's not our job to punish people for doing the wrong thing. That is not the way we're looking at it. The rules are there for a perfectly good reason, which is to deliver better care to patients, and all we care about is making sure the rules are followed appropriately. So how would we know whether the rules are being followed? Well, one of the things that, or I should say, we've just issued some guidance that explains in more detail how we're going to interpret the rules, how we're going to seek to enforce them. The sort of thing that guidance talks about is that we'll expect commissioners or those working for commissioners to demonstrate they've done a systematic review of the needs of their population, of how well those needs are being served at the present time, and then what are the options to improve the quality of care being delivered. And there are all sorts of ways in which it could be improved. It could be through the design of contracts. It could be through, and this is an important one, I think, it could be through better coordination or integration of care. And this is one of the small ways, a few ways, in which the new regulations differ from the old rules. There is now explicit reference to the role that integration or better coordination of care can play in delivering better care. Use of choice is another way in which the quality of care could be improved, and the approach to procurement might be a way of doing it. And as one of the tools that could be used in the procurement approach, there is the use of some form of competition. So it's just in there as one of the possible tools. It is absolutely for commissioners to decide where they feel competition is the right tool to be used to improve the quality of care, to secure better value for money. If there is a complaint that hasn't been done appropriately, we're not obliged to follow up the complaint. We are only, however, in this area, I should say, complaints driven, so it's only when there's a complaint that we'll be looking at things. We're not obliged to follow up. But if we do, one of the things we would be doing is just asking what is the process you went through to decide to procure services in whatever way you did. If there was a decision in a particular area which is now being challenged by somebody else not to use competition, then what's important is simply that the Commissioner can explain why was the view that it was in the best interest of patients not to go through some competitive process. It might simply be that it was clear to the Commissioner, to you, that there was really only one capable provider, and therefore there was no point in having a competition. It could be that in the process of looking at who was providing the services, who could be providing the services, that that process itself revealed who was the best provider. It could even be, on occasions, that you looked at the possibility of going through some competitive process and decided that under those specific circumstances, the costs of going through that process would simply outweigh the potential benefits to patients of doing so. So as long as there's a clear explanation, and this is only relevant, we're only going to be asking the question if there's a complaint, but as long as there's a clear explanation, then there shouldn't be a problem. The fundamental is that whatever has been done in the best interests of patients. Now, I know a lot of people talk about is competition and integration in contradiction. I think that's one of the reasons the new regulations very specifically talk about integration. They're both tools that can be used to improve services. They're not necessarily in contradiction at all. Indeed, I think one of the ways in which you could use competition is to invite potential suppliers to propose how they would provide a more joined up, a more coordinated service to your patients. And that may be a way of bringing forth new ideas, maybe new suppliers with new ideas. If we do get a complaint that something hasn't been done properly, the first thing we'll do is have some informal discussions. As I say, we don't have to take the complaint. We may decide there really isn't a case worth us pursuing. If we do decide there's a case worth pursuing, then we'll start a formal investigation. But it's worth saying, at the end of the day, all we can do is either say, if you're in the middle of a tender and it looks as though that tender hasn't been done according to the rules, then either it must be changed or perhaps started again, or if you've already got a contract in place that looks as if it's been put in place in a way that's not consistent with the rules, we can require that the contract is either changed or re-tendered. But importantly, we can't prosecute people. We can't seek that they are prosecuted. We can't fine people. It's only about finishing up in a place where whatever's happening is happening in accordance with the rules. Now, as I say, I do know there's a lot of, I'd say mythology, frankly, a lot of incorrect assumptions about what we'll do and how we'll do it and what the rules are. So we have a lot to do, I know, to explain ourselves and what it is we're going to be doing. I said we've just published some guidance and for consultation. We'll be very keen to receive feedback on that. We're working with the commissioning boards to develop a much broader set of advisory documents, guidance and so on. We're going to develop some, we already have some, we'll develop more case studies to help bring all of this to life and help people understand what it really means. And we're going to get out there and talk to the clinical commissioning groups on the ground. Again, it'll take time, and I'm sure we'll have to do it multiple times. But I want to get into a position where the people in Monitor know all of the clinical commissioning groups around the country. We're also, we provide a lot of informal advice. The CCP had done that in the past. We're continuing to do that. That'll be very important. We're also going to do some stuff on pricing, and you'll see some of that in the other consultation that we've launched just now, where we're talking about ways in which we can change the pricing arrangements to help commissioners do what you want to do. So I think I'll leave it at that, because I know you want to have some time for questions and answers.
Thanks very much, David. Hello, everybody. I'm Alastair McLellan. I'm the editor of Health Service Journal. We have a ridiculously short time to talk about a highly complex issue. I'm going to ask David a couple of questions, then I'm going to throw it open to you. So if you have questions, please prepare them now. David, early days for Monitor as well as for CCG in many of these new roles, but you must have some feel for in what cases and in which particular services greater use of competition might be appropriate or greater use of integration might be appropriate. What is your thinking on that at the moment?
I mean, I have to say that when I said it's fundamentally for commissioners to decide, that is absolutely the case. So, I mean, what we're not trying to do is to second-guess commissioners. Indeed, we've been...
You've got to make a judgment, so you've got to have a basis on to which to make that judgment.
Yes, but you see, the judgment has to be based on the specific circumstances and what a commissioner has chosen to do. So we're absolutely not trying to tell commissioners how to do their job. Now, I realize this is a delicate balance, and some people want us to be more prescriptive and more specific about this is where we think you could do better things. Others are very anxious that we don't get into that prescriptive world. We are largely trying to stay out of that and leave commissioners to work out what is...
Well, I was speaking to a lawyer last week who was very happy that you're staying out of the prescriptive world because it's generating an awful lot of work for him, with CCGs coming and saying to him, what do you think Monitor will think about this? So don't you think a greater level of guidance would be without being in any way prescriptive? Or are you simply going to treat every case on a case-by-case basis and let evidence just build up on a precedence basis?
This is the delicate balance. So I realise that if all we did was sit back, wait for complaints, look at individual cases and then publish the results of that, then the case law would build up very slowly and lots of people would be saying, but we don't know what to do and we're paying these expensive lawyers to tell us. So that's not a good position either. So you were asking me, for example, where is competition more likely to be good or useful? That's the bit I was resisting answering. What I think we can do more of is say, in a situation like this, if you ran a process in this way, would that fall foul of the rules or not? And so that's more where I think we can focus on and trying to take specific cases, because I do know people really struggle to take the sort of generic rules and work out what does that mean for me in this particular case. So I think that's where we can give more clear guidance up front.
So when might we see Monitor begin to produce this process guidance?
Well, some of it's out there already. So this guidance we published, was it last week, is first of all tries to bring the regulations to life, and secondly has got some case examples attached to it. But we will do more as time goes by.
Okay, you talked about commissioners undertaking systematic reviews of service quality and the options to maintain and improve that service quality. here's a $64,000 question. How systematic? In other words, do you need to drill down to every single service line? So do you have to review your orthopedics line as opposed to, just general acute services? And also, so what level of detail do you have to have been systematic? And also, over what time period? Do you have to systematically reviewed everything you commission within your first 12 months, or have you got a longer period to do so?
There has to be a test of reasonableness here. So we know that the commissioners have finite resources. I think what you're looking for in the first instance is that there's just been some thought into why you would focus more attention on this area than that area. Not that you would slavishly go through every area in minute detail. I doubt very much if that would be in the best interest of patients. To put enormous amounts of effort into doing something in great detail, which is not going to make much difference to what you do at the end of the day, is clearly a bit pointless. So it's all about demonstrating that you've been thoughtful about where you deploy your resources, to where you focus attention to try and improve services.
And you're going to produce guidance on what thoughtfulness looks like in that case?
Well, I think that may emerge through case law. I mean, it's a little bit difficult to sort of, again, the danger is we finish up by responding to these questions, that we finish up essentially producing some sort of cookbook, that sort of, a menu that says, if you do every one of these 27 and a half steps, you'll be following the rules. We're not going to do that. We can't do that. That's not the spirit of the way the whole thing is set up. And I think plenty of people would be very critical of us giving no independence, no freedom to commissioners to make decisions according to the local circumstances they face. So we're not going to do that.
Okay, right. I'm going to open it up to questions. We have got a ridiculously short time, so no speeches, please. Very short questions. Can you say who you are and where you're from, please?
Peter Ellis from MedWorks. I was interested in a couple of the comments in your question, Alastair, there. In terms of the environment to allow the commissioners to undertake some of those very exciting and thorough reviews, and we've been a personal involvement in it, but the environment with regard to access to information and data and the positioning of some of the more zealous Caldecott guardians, it just seems to suggest that we still have an environment that isn't facilitating the sort of competition and activity. If commissioners can't get thorough data, even though it's anonymized, what are they going to be able to do, and how are we going to deal with that?
Good question. I want to take a couple and take them in sets. Next question, please. We're very short on time, so please, if you're going to ask a question, perhaps you can answer that one on information. A lot of commissioners talk about not having the information they need to do.
Yeah. Interesting, the evidence of what been done in other sectors is that the most powerful way a competition body like Monitor can get better results for the users of a service is to empower those users. And in health, that means empowering commissioners as well. So I think working with the commissioning board, we have a big job to do to try and make sure the information is available so that you can help either make your own decisions or help patients make their decisions better.
Next question, please. Yep, sir.
Hi, from Mid-Essex CCG. Where does the balance come between competition and choice versus struggling hospitals financially and actually making them non-viable by that?
Okay, do you want to go, Dave?
I think there are two bits to that. I think what you do have to think about as a commissioner is the interdependency between services. So, for example, exposing one service to competition in a way that if the incumbent loses that service completely, creates problems in other services, you at least clearly have to think about. If you've got a provider that's struggling, however, simply because they're underperforming, then I think that's our job to worry about it. I think, I mean, of course, you shouldn't be, you shouldn't fail to think about it to some degree, and that's why I want to work with commissioners when we've got providers in difficulty. But I don't think it's a good place to be where commissioners are making, for example, decisions to take services from a poor quality provider just because they'll suffer financially if you take them away. That's not, I think, in patients' best interests.
And you think, therefore, that's quite interesting. What you're effectively saying is commissioners focus on service quality. In terms of sustainability providers, ourselves, NHS, TDA, Trust Development Authority, will worry about that. Do you think that that's... I talk to a lot of commissioners. I can't imagine them being entirely happy. Their local hospital is the centre of their health service for the community. Do you think that's a realistic hope that commissioners will be able to put a sort of Chinese wall in their thinking like that?
Well, I'm sure for all sorts of reasons it won't be as clear-cut, and indeed I wasn't even suggesting it be completely clear-cut. But I think commissioners just have to constantly ask themselves what's going to be in the best interest of my patients.
Okay. Next question, please. Yes, hand up there at the back, please. If we have the mic, can we keep the microphone in the middle, please? Then we'll get to go. Yep, sir, please.
How far do you see that EU procurement law might actually undermine the aim of integration and coordination of services? Is there anything you can say that might allay our fears? Because I think at the moment the consultation documents from Monitor don't really help in that regard. I think there is actually still that underlying fear.
Well, I'm sorry if the documents aren't helping, but I do realise it's a big challenge to explain ourselves. EU procurement law is reflected in something called the public contract regulations in the UK, which are in turn reflected in the Section 75 regulations that we've heard so much about. So in the sense, they're all consistent. Are any of them going to undermine integration? No. And in particular, this is why I think it's valuable to have a health-specific version of the rules of EU law, because the health-specific version specifically says the fundamental test is what's in the best interest of patients. So if there is a contradiction, it doesn't have to be, but if there is a contradiction between integration and competition, as long as what you decide to do is in the best interest, can be shown to be in the best interest of patients, then you should do it.
Where do you expect, you talked about acting on if complaints are brought, who do you expect to bring these complaints? Who has brought them so far, and do you think the kind of people who brought it in the past will continue to bring it? Has it mainly been private sector providers that have brought them in the past, and would you expect that to continue, or would you expect NHS organisations to begin to bring complaints?
NHS organisations already are bringing complaints. To be honest, I couldn't tell you what the historic breakdown has been, but for certain I know that there have been a significant number of NHS organisations. In fact, we were discussing one such situation early this morning.
Okay, sounds like a good subject for a freedom of information request. Any other questions? We're going to nearly run out of time, so please, I'm assuming that you understand everything about the competition regulations. If you don't want to ask any more questions, which will be an astonishing thing to have achieved in half an hour, won't it?
I'm very pleased.
All right. Charles, did you want to say anything?
No, thank you very much. Thank you for the interchange, and we'll be hearing more and talking more about this. It's not the end of the story.
It certainly isn't. Thank you very much. We thank David, please.